All right, good morning, everyone. If we can get back to our seats, please. And I think the panel is trying to avoid being here. So if I can have the panel here, please. Dr. Bilen, Dr. Masoul, Dr. Parikh, Dr. Sutka, Dr. Sheth, don't be shy. We're all friends now, and we'll still be friends after the session. Dr. Sutka, would you like to join us, please? I'm just going to call Sarah real quick and tell her to come. You got it? Okay. All right, we're going to have one of our medical oncologists be a pretend urologist for a few minutes until Sarah comes up. So it's my great pleasure and honor to be here doing this. I'm grateful to the KCA and the organizing committee for giving me this opportunity. This is in memory of my friend and mentor, Chris, who was my mentor and friend for over 10 years. On the right side of the picture, this was the Wood Fellows with Chris 10 years ago at the KCA meeting. We were celebrating his upcoming 50th birthday and also celebrating him getting the Andrew Novick Award. So it's good to be here, and I know I have big shoes to fill. I have several of the panel members here who contacted me ahead of time and told me to be nice to them. I won't mention who those are, but these are the disclosures. These are slightly modified from Dr. Wood. The panel members have not seen these cases. The cases are straightforward. There are no tricks, so don't be looking for any tricks. Please don't complain about the imaging. If you're not sure, just correlate clinically. Please don't tell me what you could do. Tell me what you would do. So you're going to give me one option, and don't tell me everything in the guidelines. I know that Chris didn't like when people said, we'll put the patient on clinical trial because that's an easy way out. I'm going to be nicer and say you can say clinical trial as long as you can name the trial, the PI, all the locations, and the NCT number. And then please keep it brief. This is not like yesterday's sessions where we can talk for a long time. So we have a lot of patients to help, and let's get going. So we're going to start with this patient just to warm up and have more people come in the room. 60-year-old man, his chief complaint is he wanted a fourth opinion. Review of systems was great, a very healthy patient. Performance status was 0. He runs marathons, travels, works full-time, and is an attorney. His GFR is 77. So this is the first set of imaging, and I'll show you some sagittal images in a minute. This is going back, just in case you missed it. Dr. Sutka, what do you see?
There's a central hilar mass in the left kidney. It is directly overlying the vessels, very endophytic, approximately maybe 3-4 centimeters.
About 3 centimeters, yep. Dr. Singer, what do you want to do for this patient?
I would biopsy him
and
enroll him on a clinical trial that we have open.
What's the number?
NCT 0025798.
Dr. Sheth, can you biopsy it?
Yes, this would be a straightforward biopsy for us.
Well, I called my IR colleagues at MD Anderson, and because that's what I wanted to do, and they told me they really don't want to biopsy it. Not you, somebody else. So that was true, actually. So what do we do now? Dr. Sutka?
I think based on the size, is it less than 3 centimeters or greater than 3 centimeters?
It's 3 centimeters, and he wants something to be done.
So if you can't get a biopsy, it's reasonable, I think, at this point to offer him a period of close active surveillance to monitor growth characteristics.
So he's going to go and get a fifth opinion now. So he doesn't want that. Dr. Sheth, can you ablate this?
It's a challenging location for ablation. This would be something that we would want to discuss with your urology colleagues to see what the other alternative options were. It wouldn't be my first choice.
Okay, Dr. Singer.
So I was actually being literal with the clinical trial. So we have a trial that's opening very soon, within the next couple of months. It's using histotripsy, so it's a focal ultrasound to essentially liquefy the tumor. There's 15 sites around the country, so he would be a good candidate. It's 3 centimeters or less, needs to be biopsy proven to be renal cell carcinoma, and he would be eligible for that trial. So I would actually offer that specific study to him, and it would be a non-invasive transcutaneous approach.
So this was 3 years ago, and the trial wasn't active yet. What do you tell him?
Then
ablation is hard.
Ablation's hard.
Do you want to radiate this?
Do I want to radiate it? No.
Okay.
So we would be looking to think about doing a difficult partial, which may end up being a total, depending on what we find intraoperatively.
Okay, Dr. Billen, is there any role for systemic therapy here?
I think other than clinical trial, I don't think so, but if we had a biopsy and this is clear cell and if this is clinical T3, we have a neoadjuvant trial, which may help, especially convert radical to partial nephrectomy. But
if we cannot biopsy it, we can't really offer him that, right?
No, it doesn't, yeah.
Okay, Dr. Parikh, anything you would do from your side?
In the absence of a clinical trial, I would not recommend systemic therapy.
Okay, so ultimately we offered him all the options as far as ablation and biopsy, and he did not want surveillance. He wanted something to be done, so we were stuck with doing surgery, unfortunately. But he did undergo a robotic partial with long ischemia time, and this is what was found. So it was an oncocytoma confined to the kidney. The easy solution here would have been to do a radical nephrectomy, but we just have to be careful when we're doing that, especially for small renal masses, especially when we cannot biopsy it. For tumors like this, I generally just biopsy first if it's a very bad location where somebody could lose his kidney or her kidney for a very small tumor. So this is what this patient had. Post-operatively, his GFR was 68, down from 77. So just a warm-up case. This is the only small renal mass case in this session. So the next patient is a 50-year-old woman, nausea and right upper quadrant pain, headaches, no past surgical or medical history, excellent performance status. These are the labs, not too bad. And this is the CT scan. I made it easy here for you too, so there you go. There's some arrows and some pointers and some sizes so that nobody complains about imaging. Just going back up now. Dr. Mastool, what do you see? Can you use your microphone, please?
I see a nasty-looking right-sided renal mass.
What's your differential for that mass?
I wouldn't be surprised if this ends up being a non-clear cell RCC.
Okay. Dr. Singer?
I'd also throw into the differential of urothelial cancer and lymphoma.
Okay. Dr. Parikh?
I agree with that.
Do you guys see the lymph node that radiology labeled for us too? Is that suspicious enough for you? Dr. Sutka?
Yes, and I think you also have to consider collecting duct.
Okay. So we did the staging workup, all was negative, so that's all great news. So what is the next step here? Dr. Billen?
Yeah, I will do biopsy.
Of what?
Of the renal mass.
And what about that lymph node? Would you want to know what that is?
Yeah, I think that is also an option, but it's a small lymph node. I don't know whether IR can target that lymph node or not. If yes, I think it will be great. If not, at least kidney biopsy.
Well, let's ask our colleague, Dr. Sheth.
At the risk of throwing my colleagues under the bus again, I think we can very straightforwardly biopsy that lymph node.
Okay, well, this is real, but I've asked for a biopsy of both the kidney and the lymph node, and I got on the phone with one of our IR colleagues, not Dr. Sheth, and they told me they really, really don't want to biopsy that lymph node. So does anybody disagree with biopsy on the panel? Anybody wants to do systemic therapy first, or surgery first, or radiation? No? Okay. So this was the biopsy. So yeah, you're right. The differential was something that's not clear cell. Some sarcomatoid dedifferentiation was on there too, urothelial, lymphoma, and others. So this was papillary RCC from the kidney. So what is the next step? Dr. Sutka?
So the only disease is confined to the retroperitoneum.
That's it, no surprises.
So I think that you could offer this patient surgical removal of the kidney and a retroperitoneal lymph node dissection.
Okay, Dr. Singer?
Agree.
Dr. Masoul, systemic therapy or surgery?
Cut it out.
Okay. Dr. Parikh?
I agree with everyone.
Okay. So that's what we did. The reasoning here was this is a papillary RCC, only one lymph node was suspicious at the time, although there was actually some para-aortic lymph nodes that were prominent. So we talked to the patient about the option of systemic therapy or surgery, and we did offer her surgery with the potential of maybe curing her. So this was just a nephrectomy with a complete bilateral lymph node dissection. Pathology confirmed it was papillary, and one of the lymph nodes, just the one we saw in the imaging, was positive. So it was a T3A and 1 because there was renal vein invasion as well. So what do we do now? Dr. Bilen?
Yeah, based on no data for adjuvant checkpoint in the non-clear cell, I will do surveillance.
Surveillance. Dr. Masoul?
Did it have any sarcomatoid features?
No.
It looked nasty looking. You know, if the recurrence risk is high enough based on our prognostic nomograms, I might consider discussing adjuvant therapy, otherwise surveillance, no radiation.
Dr. Parikh, do you agree with adjuvant therapy in a non-clear cell patient?
I would do surveillance on this patient.
Okay, Dr. Singer?
Surveillance.
All right, so that's what we're doing. So the first scan, this is just recent, has no metastatic disease, and the plan was to surveil every 3 months for the time being and hope that we don't see anything come up. Another patient, a 62-year-old man, abdominal pain after radical nephrectomy done somewhere in a different hospital a year before that. So he has a history of kidney cancer, diabetes, hypertension, high BMI, and chronic kidney disease. Surgical history was left hand-assisted laparoscopic radical nephrectomy. The outset pathology was re-reviewed and showed chromophobe kidney cancer. Stage was T1 and the margins were negative. However, when you look at the gross pathology description, the specimen was received in more than one piece. And this is the MRI, so we have some still images here. What do you see, Dr. Sutka?
It looks like there's, in the renal fossa, we see a solid tissue, soft tissue signal that looks like potentially local recurrence.
Okay, Dr. Sheth, what do you think?
Yeah, so the T2-weighted images, you see multiple, these T2 hyperintense lesions along the fossa. So this looks like some residual recurrent tumor from the resection.
Okay, there's some deposit by the spleen as well, the renal fossa, like you said. Dr. Singer, anything else?
Yeah, I just want to see the rest of the staging imaging.
You have to correlate that clinically, but staging otherwise is good.
Great.
So CT chest, MRI brain, all that is good. So what do we do next? Dr. Singer?
I would offer either...
One option?
One option. I would do a...
You can choose other stuff that's not here too.
Yeah, no, I mean, I would offer him surgery for essentially drop metastectomy,
Okay.
possible splenectomy.
Okay. Dr. Sutka?
I think that surgically clearing the retroperitoneum and the fossa is your only option, given that it's chromophobe. So I would, as long as there's no disease anywhere else, I think there's multiple foci of
This
recurrences.
looks like it at this point. Dr. Sheth, would you ablate any of these lesions?
So, I mean, in a patient who has all these additional comorbidities, if surgery would require a massive resection, including splenectomy, I would put ablation on the table.
Okay. Dr. Bilen, would you give him systemic therapy? It's a chromophobe RCC.
No, not my primary choice. I think local control is key.
Okay, Dr. Parikh?
Yeah, similar to Dr. Billen, I think in the absence of further metastatic disease, I would favor local therapy.
Okay. Dr. Masoul?
This is so sad. It will at some point recur as well in the peritoneal cavity, very likely, but until then, I would do metastasis-directed therapy with ablation or radiation therapy.
Okay. And then this was many years ago now, and we had even less medication options at that point. And the thought here with this looks like it's a surgical misadventure, not true biological metastasis. So that's what we did. And these are the types of surgeries that we have other colleagues invited to the surgery ahead of time in preparation, because a lot of stuff can happen here. So how would you do the surgery, Dr. Sutka?
Midline approach, have general surgery, my hepatobiliary colleague on standby, because we're likely going to have to take out that spleen. The bowel is likely to be matted down, but you're prepared for the mobilization and how challenging that'll be. It is a transperitoneal approach, and just explain to the patient that the regional organs are at risk, and so you have to have a very careful, informed consent conversation.
Okay, Dr. Singer, anything else?
Nope, Thompson retractor.
Okay, that's exactly what happened. So we did this through an open midline incision, and these are the things that had to come out. The masses usually remove the artery and the vein stump in redo cases, the adrenal, the pancreas, the spleen, the colon, the omentum, the diaphragm, and the lymph nodes. So pathology confirmed RCC, and this was all, I wouldn't call them drop mets. I mean, they were just tumor spillage. The good thing is that there was no frank carcinomatosis all over the peritoneum, so these are discrete lesions. So we ended up doing surgery. What would you do now? So 6 weeks afterwards, scans are okay. Any adjuvant therapy, radiation, or observation? Dr. Parikh?
I would favor observation.
Okay. Dr. Singer?
Observation.
Okay. So that's what we did. He did well for a couple of years with no evidence of disease. We were scanning him. He's from abroad, so he would come every 6 months or send us his scans. But then he had 2 years later, contralateral lymph nodes. So I did not do a full bilateral node dissection because we had other stuff to do that day on the same patient. So no other mets. Bone scan, brain, chest is good. Just lymph nodes this time on the right side. Dr. Sutka?
Depending on his performance status and whether
He's still doing great.
Surgery.
Okay. Dr. Singer?
Same.
Dr. Masoul?
Biopsy and metastasis-directed therapy.
What does that mean?
Radiation, ablation, surgery.
Okay. So radiation at that time, where people weren't excited about it as much as people aren't now. So we had really limited options at the time, and end up doing a completion retroperitoneal lymph node dissection. Again, hoping that this would at least help set things off a little bit. 1 year later, he had a seminal vesicle mass. I don't have an image here, so it was very close to the rectum, and the same thing. We don't have a radiation oncologist on the panel, but they thought it was way too close to the rectum for their comfort. Dr. Sheth, what are your thoughts on ablating something that's immediately adjacent or adherent to the rectum?
If it's adherent to the rectum, then there's not many options for us. But if you can dissect it away, then there are ability for us to treat it for local intent.
And that's what we did. So he saw one of my colleagues who does more pelvic surgery than I do, and he had a robotic, actually, seminal vesicle mass resection, which I'm glad that somebody else did that. Anyway, the patient, unfortunately, he did well for some time, but then he had liver metastasis. And I don't have the images now, but he did undergo ablation of some of the liver metastasis and then had a recurrence, and he's currently on systemic therapy. I won't tell you which one because I will talk about the same disease maybe later. But he's now doing well, I think close to 10 years or so after the operation, reasonably well as one can expect. So next patient is a 65-year-old man with right upper quadrant pain, no issues with the review of systems and otherwise. These are the images. I'm just going to go through it upwards one more time just in case you missed it, so that nobody complains about the bad imaging. Dr. Sheth, what do you see?
Subtle lesion in the lower pole of the right kidney, and as Dr. Su was pointing out, there's also some lesions on the left kidney as well, and I think some enlarged lymph nodes in the retroperitoneum.
Yeah, that's exactly right. So what do you want to do now? Dr. Singer?
I would go ahead and get a biopsy to figure out what's going on in terms of his bilateral disease.
What do you want to biopsy?
I'd start simple and hope that your interventionalist could hit the kidney.
Okay, I think that one they can get. Yeah. You want to do the right side, left side, both?
If they can do both, that's fine, but right side is fine. I'd ask for a couple of cores. I don't want them to send me necrosis.
Sounds good. Dr. Bilen, what would you do?
Yeah, I agree.
Dr. Parikh?
I would biopsy.
Okay, Dr. Sutka?
And biopsy, but make sure we did both sides.
Okay. So we just biopsied the right side, and it showed papillary RCC versus MTSCC, or mucinous tubular spindle cell carcinoma. So what's the next step? Dr. Masoul?
If possible, resect the right kidney mass first.
Okay, Dr. Parikh?
If feasible, yes, I would agree with resection.
Dr. Sutka?
Right nephrectomy and RPLND, and talk about a potential left partial in the future.
In the future, not at the same time.
You can do that if a patient is very healthy and tolerates the dominant side, but I think here the left side is about 3 centimeters, slightly.
There are multiple tumors, and they're not the easiest location.
Yeah, I think that's too much in one day, and also I'd want to see where his kidney function settles out, and then you do have other ablative options because those look like they would be amenable to either thermal ablation and or potentially stereotactic radiation. So you've got other options to treat those.
Okay, so that's what we did. We took the patient to surgery and did surgery only on the right side, given that the left side was not going to be easy at all. And this was the pathology. So it was confirmed to be a mucinous tubular spindle cell carcinoma, and there were 6 oncocytomas in that kidney. And you can see the sizes here, and 2 of the lymph nodes have cancer in them. They're less than 1 millimeter in size. So what do we want to do now, Dr. Parikh?
And they didn't do surgery on the other side yet?
Nope, we just did the surgery on the right side.
So
what's the next step?
I would try to treat definitively with further surgery if possible.
Surgery on the left side. Okay, Dr. Masoul?
Surveillance for a few months to see how the left side behaves, see how the kidney function is, and then consider localized therapy, if possible, to the left side.
Okay, Dr. Sheth?
I would agree with that. I would wonder, though, if you want to get a biopsy of these lesions on the left side before treating.
We kind of decided to watch it for a little bit just because of the extent of the disease and the lymph nodes. We were worried more about systemic disease happening from the lymph nodes, that we encountered, and we didn't really want to endanger his left kidney. I did not think even at that time, and this was years ago, that the partial nephrectomy would be very doable yet. But so we watched the patient, and this is some scans right now. Just pay close attention, please. And I'm not interested about the gallbladder thing if anybody wants to comment on it. So just what do we see, Dr. Singer?
It looks like we've had some growth in the left side, and it looks like we've got some hydronephrosis in the left as well.
Okay. And do you want to comment on the liver lesions?
There's liver lesions as well. So again, the surveillance piece was a good plan.
Yeah. Dr. Sheth, what do you think?
I think I need to see the images again. Do you mind scrolling back through the liver?
What's that?
Do you mind scrolling back through the liver?
It could. What do you think, Dr. Parikh?
I agree. Are you asking about further treatment?
What do we do now?
Yeah, I mean, in the absence of a clinical trial, you could try systemic therapy with a VEGF TKI, such as cabozantinib.
Okay. Dr. Sutka, what do you want to do now? So he's got these liver lesions. He's got the left kidney masses are getting bigger.
Yeah, I mean, the left kidney masses at this point. So, quick question: has he had genetic testing?
He did have it later, but it was negative.
It was. Okay.
Yeah.
So, I think you're running. The issue is, and we didn't biopsy the left because we don't know if those are oncocytomas or not. Because even growing oncocytomas, that can continue to happen.
So this is what we have right now. We have liver lesions. We have left renal masses that are growing. What do you want to do now?
I would biopsy the liver and I'd biopsy the kidney. And then I would think about if you're still in a window where you can actually partial the kidney and save it, because otherwise he's going to be on dialysis.
Okay. Any other thoughts, Dr. Masoul?
I would like to know the tissue diagnosis in the liver.
Okay.
And also the growth kinetics, you said 3 years. Those liver lesions just pop up, like, or slowly growing?
They were there, barely perceptible, but now they're pretty obvious.
Okay.
So, you know, some people here on the panel were very fatalistic and nihilistic, which I think, you know, we got an MRI to be sure, and there were thankfully hemangiomas. The biopsy was ultimately done on the left side, and they're favoring oncocytoma. So what do you want to do now, Dr. Sutka?
Well, they're benign, but they're growing, which means that you're running out of time in trying to save that kidney. And
Okay.
so I think you have to do something locally. I think that based on the multiple central masses make them not a great thermal ablation candidate. So I think if you can do a partial, a multifocal challenging partial, understanding that you might need some dialysis to limp that kidney through, that may be something you can talk to the patient about. But it comes down to his goals and his willingness to accept that risk.
Okay, Dr. Singer?
I'd be more inclined to continue surveillance if we're thinking that these are in fact oncocytomas. The growth has been there, but it's been within reason of what you'd expect to see an oncocytoma growing over 3 years. So if he really wants to avoid the potential for dialysis, continue to monitor.
Okay, I mean, keep in mind, this was, I think, 3 years into my practice, and I was trying to do no harm at the time, and so decided to keep watching him. That liver thing is a hemangioma as well now. So let's look at the left kidney now. The gallbladder is still there. So this is now 6 years after the right radical nephrectomy with positive lymph nodes. What do we want to do now, Dr. Sutka? I know you still want to do a partial.
So that's a challenging multifocal partial.
Now it's become challenging? Okay.
It was challenging to begin with, and now it's varsity. I think the issue is that it looks like you still have a lower pole that is relatively uninvolved.
If you squint hard enough, you can see some kidney there, yeah.
But the problem is these are continuing to grow. So I think at this point, the conversation comes down to...
What do you want to do?
Keep him going as long as possible with his kidney in situ, and then at some point have a conversation about listing for transplant.
Okay, Dr. Singer, you want to still watch, or you want to try to do a partial or a ablate or others?
If, based on the growth, I would get another biopsy to make sure we actually have what it is.
That's exactly right. So whenever we have these masses that we think are benign and they grow, it's a good idea to recheck. So we biopsied other masses in that kidney, and it looks like it's all the same stuff. Dr. Masoul, is there any systemic therapy we can use here?
Not validated. We have tried in oncocytoma, metastatic oncocytoma, cabozantinib, and have seen responses. But again, you're committing somebody to a TKI with side effects, etc. So I wouldn't recommend it in this case.
Okay. So now it's 9 years post-op. And this is what we have. Dr. Sutka, partial.
So he's now 59, and his kidney function is still okay?
Yeah.
And he's not symptomatic.
So GFR is 41 right now.
I think you can continue to monitor these benign tumors that unfortunately are growing, but as before you're talking about, at some point he will likely lose enough renal function that he will need to consider dialysis and transplant.
Okay. Dr. Singer?
Keep monitoring and get fewer scans.
Every 3 years, come on. So he's now in his 70s and 9 years post-op from the original surgery. Just in case you were wondering, his GFR was 44 about 9 years ago. So the tumors might affect his kidney more in the future, but at least at this point we're kind of getting away with just doing monitoring for him, less frequent monitoring. So this is an 89-year-old man. He's lived a good long life. He's had a lot of stuff happen to him, unfortunately, in that time. He was referred to my clinic for a right partial nephrectomy. That was the prescription, referred for a robotic right partial nephrectomy from an outside institution. He's had colon cancer, has had surgery, prostate cancer, has had surgery, kidney cancer, has had biopsy and RFA elsewhere in 2010. Bladder cancer, had surgery, and just to make it more fun, he had shockwave lithotripsy on that same kidney. Family history of prostate cancer. This is the imaging prior to the RFA, and just take a good look at the images here. So this is 5 years before he showed up. Dr. Sheth, what do you see there besides the right renal mass?
So this looks like potentially a vascular lesion. I see, I think, some sort of early venous filling of that.
Yep, so it looks like he's got this very small tumor with a renal vein branch thrombus that probably was not ablated at the time at the outside institution. So when he showed up to clinics, GFR is good, labs otherwise are good, CT chest shows no metastatic disease, and you could see here the ablation defect. And this is the patient that was referred for robotic partial nephrectomy. So Dr. Sutka, I'm just going to run through this. Would you do this partial robotically, or would you do something else?
So he has an IVC level 2, it looks like. It's probably about 2 centimeters above the ostium, IVC tumor thrombus.
Yeah, so he does have that. Metastatic disease is not present. He's 89, has had a few surgeries happen to him before. So Dr. Parikh, what do you want to do for this patient now? He had a biopsy at the time, it was clear cell kidney cancer before his RFA. Would you give this patient immunotherapy at this point? He's 89, had multiple surgeries, and has an IVC thrombus.
And he hasn't had surgery yet.
Not for the kidney at this point, yeah.
Yeah. So this would be a tumor board discussion. I would be open to starting neoadjuvant therapy in this patient, but it's without data.
Okay, Dr. Masoul, would you do neoadjuvant therapy in this patient?
I would like to get a better feeling of the kinetics. I know that there is, the IVC thrombus that is concerning, and if, there is substantial growth, I may consider neoadjuvant therapy, but I'm also inclined towards observation. He's an 89-year-old guy that, may never be harmed from this.
Okay, Dr. Bilan?
Yeah, I think this is a fair discussion. If the surgery is not an option, then I think maybe IO-IO combination can be used, but definitely if the surgery is not an option.
Okay.
I always hesitant to watch too long the IVC thrombus.
Okay, Dr. Singer, what would you do for this gentleman?
I'd want to understand his differential renal function. So
We didn't check that. The left kidney looks okay.
It looks normal.
GFR is in the 60s now, so we're not.
If I was going to offer a surgery, I'd think about just doing a total nephrectomy, IVC thrombectomy. I think doing a complex partial with the increased risks when we have a normal contralateral kidney, I don't think that would be worth the risk.
I think the referral was because the IVC thrombus was missed and there was
Yeah.
just a local recurrence. So I think it's manageable. Dr. Sutka, what would you do for this patient?
I would offer him a right radical nephrectomy and IVC thrombectomy.
Okay, Dr. Sheth, would you ablate this again?
No, I would not.
You didn't do the first time, but any role for radiation therapy in this patient as a primary treatment? I know we don't have a radiation oncologist on the panel, but yes, no? Everybody's shaking their head. Okay.
We saw a good presentation yesterday from Dr. Sood arguing for radiation to the IVC thrombus to improve surgery, so I think it's something that needs to be studied.
The one thing I didn't mention is this is an 89-year-old man that's extremely sharp, walking to clinic, fighting me about all his blood work. Why is the neutrophil count 0.1 above normal? So that is very important to see when you have a patient clinic that's coming and shaking your hand and looking at you and talking to you is different than somebody coming on a wheelchair, for example. The performance status and the frailty are very important measures when we take care of these patients. So he did have surgery. It was difficult for all the reasons I mentioned earlier. Clear cell, grade 3, T3B, negative nodes and margins. He did have genetic counseling because of his family history, and he's had at least 4 cancers. We decided at that time there was really no adjuvant therapy that we could do anyway. He's almost 90 years old, and so far he's 4 years post-op, and he's still with no evidence of disease. So this is another patient who's 80 years old, some incidental renal masses. Just somebody decided to do an ultrasound because of elevated LFTs. He's had 5 stents placed a couple of years ago, and just some hernia repair, no family history. This is his CT scan. Dr. Singer, what do you see?
seeing two large renal masses, so bilateral renal masses here.
Okay, Dr. Sheff, what are your comments in depth on these renal masses if you want to compare them?
I'm trying to see if the one on the left has some internal calcification. The other one on the right seems to be a little bit more hypervascular. Okay,
Dr. Sutka, what are your thoughts on the masses?
The one on the right appears to have central necrosis. The one on the left is more homogeneous. They are just slightly different phenotypically, and it makes me wonder if they're the same histology.
Okay. This is a GFR is 45, no metastatic disease. We talked to cardiology just in case we need to do anything at all for him. What would you do next, Dr. Sutka?
Quick question. Is the vein involved on the right? I would biopsy both sides.
Okay. Dr. Singer?
Agree.
Dr. Bielen?
Agree.
Okay. So we did just that. The right-sided biopsy, as you've expected, clear cell was found to be low-grade on a small specimen. Left side is a renal oncocytic neoplasm. What do you want to do now, Dr. Sutka?
Understanding his cardiac comorbidities, I think...
Cardiology said he's fantastic, he's good to go.
I would talk to him about a right radical nephrectomy, possible RPL&D.
And what about the left side?
I think right now I would monitor that. Given it's an oncocytic neoplasm, it's not cancerous.
Okay. The GFR is kind of in the 45.
We didn't see the rest of the right kidney. I think one question you have to ask is whether or not it is something that you could do a complex partial on, understanding that.
This is the two images that I think are
it's enough.
Pretty representative. Would you do some neoadjuvant therapy, Dr. Masoul?
No, not necessarily for this one, because I don't think it will, we have enough data that it will affect the left kidney mass, and I think that hopefully the right kidney mass, which is the real problem, can be resected.
Okay. Dr. Bilen?
Yeah, I totally agree.
Dr. Parikh, would you do neoadjuvant therapy in this patient?
No.
Okay. Dr. Singer?
Right nephrectomy.
Okay. So we talked to the patient, and this is the biopsy result, and decided to observe the left side because it was oncocytic and it was pretty bad location as well. Decided to try to do a partial nephrectomy on the right side, open partial nephrectomy. We're able to actually do it. There were some margins around it. It was still grade 2, invading the vessels and negative margins. What do you want to do? This is postoperatively GFR went down from 45 to 35. What do you want to do for the left side right now? Dr. Sutka?
I would monitor it.
Okay. Dr. Singer?
Same.
Dr. Parikh?
I would monitor it.
Okay. And let me see. That's what we're doing. I think we're out of time, right, Phil? Okay, I think this is it then. Sorry we only had 40 minutes to do this, but I appreciate you all being here and being good sports, and thank you all for your input.
Thank you.